me.
So you're very welcome, Adejumoke, and really looking forward to this evening. I met Adejumoke out in Frankfurt in Germany a few months ago, and she's so passionate about perio. It's very exciting. I'm going to let you know a little bit more about her in a few moments when everybody comes in. So welcome everybody this evening to the Ikigai Oral Hygiene Programme. When you ask us for topics, we do go and research. So we went and asked Adejumoke, and I think you're really going to like this presentation. It is something I think, even for myself personally as a dental hygienist, I have to keep recapping and making sure that I'm up to date with the latest information. So this evening is going to be great. Adejumoke is a specialist periodontist, and she has done a master's degree in Glasgow. She's completed her PhD, so quite a lot of studying, Adejumoke. Undergraduate, postgrad, she's involved in undergraduate, postgraduate, specialist training in periodontology in 2020. She's a researcher, and she's presented and published her work nationally and internationally. She can tell you a little bit more about herself perhaps as we go along. And just remember that this is on demand. Please give us a chance to get it up onto the website if you want to watch it back, which you probably will want to watch this back to get some tips. And also, please just give marketing a chance to send out the emails, fill in the evaluation. Please check your junk mail, because sometimes they don't always go into the inbox. Fill out the evaluation, and then your certificate will be sent back. Adejumoke, thank you very much. I'm going to hand the reins straight over to you and let you start this evening. Thank you.
Thank you very much for having me, and hello everyone, and thank you for joining us this evening. I'm just going to share my screen, and I'll be grateful, Siobhan, if you could let me know if you're still seeing the right view setup for this.
Yep.
I just want to bear with me. Is it swapped over again?
It's swapped over again, yeah.
Okay, that's fine. I will
well, you
swap
know
that
what?
out.
Yeah.
Lovely. So I'm sure it should be okay
Yeah,
now.
we're perfect now. Thank you.
So thank you, everyone. And thank you for the introduction, Siobhan. I am a senior clinical lecturer at the University of Liverpool, as well as an honorary consultant in periodontology, and I'm passionate about all things perio. So, and when I was asked to talk about radiographs and perio, I think I would sort of say that what my thought process was with this presentation was that I was sort of looking at a lot of the referrals I get, as well as a lot of the questions I often get asked by hygienists, by therapists, and even dentist colleagues as well, with regards to utilizing radiographs in managing patients specifically suffering from periodontitis. The aims for today will be to provide an update. I'm not trying to teach you to suck eggs. I'm not going to go over the science per se. I am going to be quite pragmatic in my approach. So I'm just going to give a bit of an update with regards to the role of radiographs with regards to diagnosing periodontitis in particular. I am not going to cover dental implants or other conditions that affect the periodontium in this talk tonight. I'll also be giving a bit of an overview with regards to indications for when it will be appropriate to have or undertake further radiographic investigations as it relates to the clinical management of our patients suffering periodontitis. And with regards to the objectives, the main focus will be discussing and also evaluating the importance of radiographs as it relates to us making diagnosis and how that would enhance our patient-centered decision making, as well as giving a bit of an overview about radiographic techniques that are available, what the advantages and disadvantages of the different techniques are, and possible indications for various radiographic investigations as a patient progresses in their journey with us as clinicians. So, like I said, when we talk about periodontitis, based on the 2017 classification, there are a variety of conditions that will come under periodontitis. We've got necrotizing periodontal diseases, which is more of an acute condition affecting either the gingivae, the periodontium, or even extending into the soft tissues, such as the cheeks, for instance. Um, you've got periodontitis that might present as a manifestation of systemic disease, and that usually would require multidisciplinary care. And then we have what I would call our bog standard periodontitis, which is our bread and butter in terms of us seeing that those sort of patients every day. And that those are the sort of patients I'll be talking about in great detail today. Again, we all know about the staging of the disease, as well as the grading. And really, I think one of the things I did like about this new classification system when it came into the place was uh, the they made it a criteria that you needed to have radiographs to be able to actually come up with a diagnosis statement. Um, so why are radiographs important? Obviously, they're a type of clinical imaging system. They aid our clinical assessments and discussions. And I think one of the great things about them is that they are useful as well for having those discussions with patients when you are discussing your findings and your diagnosis, and hopefully utilizing them. I do utilize them in my consultations to explain the disease process to the patient so that it aids their understanding of what's going on. Um, from my perspective, I feel that it helps the patient in terms of them feeling empowered because they have a better understanding, and it does support their adherence to oral hygiene advice that you might provide the patient as part of their care. For us as clinicians, obviously, it is pertinent to arriving at a diagnosis. But I think one of the things that I'd encourage us to remember that it has to be used in conjunction with the information we get from our history taking, our clinical assessment of the patient, and that it should not be utilized purely on its own to arrive at a diagnosis. From an advantage point of view, it definitely adds to our clinical assessment. Personally, in my clinical practice, um, after assessing a patient, yes, you have a bit of a rough idea that this patient is likely to be suffering from periodontitis or even perhaps some complications of it. And you do get clarity because once you've undertaken that radiographic investigation, you get a better idea of what might be going on. And as a result, it underpins and strengthens the information that you have collected as part of your history and clinical examination. Obviously, with periodontitis, a key feature of it is bone loss, and without our radiographs, we cannot establish that by just looking at the patient, unless we have X-ray vision ourselves, which I doubt very much if anyone has that sort of superpower. So clearly, it is really important, and I've put this panoramic view there just to sort of remind us that about why it's important to try and establish a diagnosis uh, right from the onset, and also to reevaluate our diagnosis statement from time to time as we reevaluate treatments, at recall appointments or reevaluation appointments. And I think here, one of the things to sort of bear in mind is how much bone has been lost, and perhaps the beginnings of very early focal bone loss, etc. So we get a lot of information apart from bone levels from our radiographs, and I will talk you through about how we undertake our periodontal assessment or key things we should be looking out for. And like I did allude to before, if you look at this flow diagram, your radiographic assessment is really important. And with the BSB guidelines as well, the choice of radiograph, and I will sort of go over this as we go along, is actually dependent on the clinical case. I know there are people that are very, very pedantic or that will strictly adhere to periapicals only, but there are scenarios where a panoramic view might be acceptable as well. I think, but what is more important is that you do undertake that assessment once you have undertaken your history and clinical examination, because that helps us in terms of determining what the staging and the grading is all about. And then that fits into our diagnosis statement. When we're talking about radiography in particular, I think you could sort of think about it in two ways. We've got the conventional radiographs, which is what we are all used to, and then you've got the computerized tomography, which it's become more popular in the last decade or two. So with the conventional radiographs, when I was an undergrad, we had purely analog radiographs, which were your wet films, which you would expose the patient to the radiation with them holding onto the film. You would develop it, and then as part of your processing system, and then you would utilize that. More recently, over the last 2 decades, we now have digital radiographs, which have made life a lot easier, because obviously with the analog, it was quite cumbersome. With regards to your physical handling, you tend to have more processing errors. You needed to have quite a lot of physical storage space to store them, and you could not manipulate the images in terms of trying to lighten the contrast or brightening the radiograph, as it were. With the digital sensors, initially they were quite bulky because you have the direct and the indirect types. Initially, the direct types were developed, and they were either charge-coupled devices or complementary metal oxide semiconductors. And both systems, irrespective of which one, contained silicon crystals, which converted photons to electrons. With the main difference really being how the pixel conversion took place. With the CMOs, which is the complementary metal oxide semiconductors, they would convert at pixel level, whilst the charge coupling devices transfer to a common output source. More recently, we start using indirect sensors, which use photo-simulated storage phosphor plates as sensors. And the beauty of this is that they're quite thin and similar to the conventional radiographs films. So you could have really tiny films that you could easily insert into the intraoral films that you could insert into the mouth. And once these plates were exposed, they were processed in a digital scanner, which produces a really high quality image. So that has led to the ease with regards to manipulation. There is really no need for physical storage. And the beauty of it as well is that it can be easily shared. So in the past, I remember when I was training, we used to have referrers send in referrals, and then they would have to send in a physical radiograph as well, the referral. Now all you get is the online referral, which makes life easy, and you can see the images straight away. So with the conventional radiographs, obviously we're all well aware of this, and we've got the bite wings radiographs, which are great for assessing for interproximal caries. in patients with clinical gingival health and not an issue because you can still see some amount of the crestal bone levels. With very early bone loss, again, you might still be able to make some judgment with them. Obviously, with the bite wings, you have the horizontal or the vertical bite wings. With the horizontal bite wings, probably better if you were sort of having periodontal diagnosis considerations because you got more of the tooth morphology and anatomy in view as opposed to the horizontal, which sort of focused more on the coronal elements of the tooth, as well as some very uh, early bone or more coronal crestal bone levels. The challenge with bat wings, as you all are well aware, is that as you start to have really severe bone loss, it's very, very difficult for you to estimate. And obviously, you're not getting the apex of the tooth. You're not able to see the tooth or the root morphology in great detail. So there's very, very limited benefit when it comes to uh, utilizing that particular view for periodontitis patients. However, if there were other things you were wanting to look out for, like I said, like caries, then yes, it wasn't an issue to utilize those. Periapicals are probably the most ideal choice of radiographs for uh, trying to assess a patient that's suffering from periodontitis, and that's because you can see the whole tooth and you can see the surrounding structures. So it's great from that perspective, and really will be the ideal choice of you. But that is not to say that it always has to be a periapical radiograph that has to be undertaken to arrive at a diagnosis. The panoramic views are great as well, especially when you have patients that cannot tolerate intraoral views, and they do give you an overview of what's going on in terms of your bone levels. You might be able to identify if there's some periapical pathology, furcation involvement, the pattern of bone loss, etc. There are limitations as well in terms of the level of clarity, and that's why I can appreciate the school of thought that is really, really pro periapicals at all times. But I think there's still a wealth of information that you can get from them. Obviously, you've got that superimposition of the of the cervical spine against the anterior teeth. So if you were going to be looking out for what was going on and wanting to get a measure of detailed information relating to your anterior teeth, they're probably not the view to utilize. But say, for instance, if you had a patient that had code fours everywhere, you could do a combination of maybe anterior periapicals and an OPT. And increasingly, we've got machines that are great and you're getting better OPTs these days than we previously had. So moving on to indications for radiographs, why do we take them? For a variety, like we've already alluded to, diagnosis is key. It does help with our staging and grading when we're sort of trying to determine what the severity of bone loss is, and also trying to predict what the rate of progression of the disease is likely to be. It's very important in terms of care planning, especially when you're having very complex cases where you're having atypical root morphologies, or you're getting furcation involvement, or you're having periapical pathology involvement as well. So you do really need radiographs to help with that. And again, once we've diagnosed and we've come up with a plan as we start to carry out treatments for our patients, again, there are instances or situations where we would require monitoring for or assessing non-responsive sites for a variety of reasons. One might be to determine if there was anything you'd missed out previously, or whether there was a cogent reason for the deterioration of a site, or just trying to establish why a site might be non-responsive, especially in very well-engaged patient. And ultimately as well, it does help you determine if a referral to a specialist is necessary. So I give you an example. This was one of the patients that had referred to me, a lovely lady in her early 40s with some periodontitis that had, obviously you can tell that her plaque control perhaps not the greatest. She's got calculus around this lower anterior teeth, but the problem was with this extremely increasingly mobile tooth that, and with the radiographic view there, you could see that there was extensive bone loss there with a vertical pattern of bone loss. And it was trying to make that decision as to what could be done with regards to whether we could save this tooth or not whilst managing the patient's periodontal condition. So for this sort of patient, a radiographic investigation is essential to coming up with a care plan for them. Now, I think one of the things, and this is just sort of going back to basics to just serve as a reminder for us as whichever radiographic view or that we utilize, it's important that we remember what our reference points are. And it's about going back to your anatomy. You've got to be quite systematic in how you view your radiograph, whether you're just looking at the coronal structures first, looking for any radiolucences that you might be seeing that might be demonstrative or indicative of dental caries, or even maybe cervical burnout, or what the bone levels are. And then you go into the roots to determine whether there is any anatomical abnormalities there, or even within the root canal system as well. And obviously, this is juicy for us as clinicians, in the sense that when you're seeing evidence of an subgingival calculus that you can't wait to get rid of when you start managing the patients. But I think when you're sort of thinking about your crestal bone levels, you need to remember that the CEJ is a really critical reference point. So your cementum enamel junction. And there are very few variations that we've got to remember that in teenagers, even with a healthy periodontium, that the alveolar crest is anything from at the CEJ to a couple of millimeters apical to that CEJ. But for a lot of adults, because you're having constant modeling, and so you're getting remodeling and deposition of bone, we tend to have, as we get older, that alveolar crest being about 1 to 2 millimeters apical to our CEJ. And we need to take that into account when interpreting our radiographs. I think what I'm trying to say here in terms of when we are undertaking our radiographic assessments for patients with periodontitis, your BPE, which is just a screening tool, nor your radiograph should be, none of them should be utilized in isolation. You've got to look at the entire picture, because neither is sufficient to provide you with a periodontal diagnosis. They might be indicative that something's going wrong, but you've got to holistically look at that patient and taking into account what their history, what your clinical examination findings are in addition to this. Because, for instance, when you look at these two radiographic views, if you look at the images of the back wings and the top right of the screen, this had similar BP codes. And when you look at the bottom of the back wings, you can clearly see that there's been tooth loss. You've got some bone loss here and there, yet they are presenting exactly the same. So it's really important that you're looking holistically, because you could have the same BP, but you'll have different clinical presentations and radiographic investigations. And you need to take that into account as you try to formulate a periodontal diagnosis for patients. And I think one of the things I always say is that without a periodontal diagnosis, you cannot have a care plan in place because you're likely to misplan that patient. Now, when we are undertaking radiographic assessments for our patients, we need to be systematic. And for me, I try to do it in this way, which I'll be sharing with you. First thing I sort of look out for is the extent. And when I'm talking about the extent, I'm trying to determine whether it's generalized bone loss, i.e., you have greater than 30% of sites affected, or localized to a particular area, or whether we have more like incisal pattern. And I think one of the things we've got to remember is that no two patients are the same in terms of how the bone loss pattern is in patients with periodontitis. And that's why we have different patterns. And for patients, you might find out that you've got the maxilla being more extensively affected compared to the mandible. So there is a huge range of variety that of presentations when it comes to the extent of bone loss with patients. Another thing we need to be looking at is severity, and that's where our staging comes into play. Because with the severity, you are looking at how much bone loss there is from a coronal to an apical aspect. And you could classify that in terms of percentage, or if you've got measuring tools, again, it could be mild, moderate to severe, where you could measure. Or again, like if we go back to the BSP guidelines, you could sort of use the rule of thirds, where you have the coronal third bone loss extending within the coronal third of the root length, the middle third of the root length, or the apical third of the root length. I think another thing that is really, really critical as a clinician that you need to look at carefully once you have determined that what the extent and what the severity is with regards to the bone loss is the pattern. And this sort of gives you a good indication of what might be going on, because you have generally, you could have a horizontal pattern of bone loss where everything appears flat generally, and it's sort of going down in an even manner. Or you could have vertical bone loss when you've got angular defects here and there. Or you could actually have a mixture. So you have a variable pattern of bone loss. And obviously, it's also important that we're looking out for furcation involvement, because that gives us an indication of, from a prognosticating perspective, how challenging treatment might be, as well as what the likely treatment outcomes or prognosis for that tooth or teeth may be. With the patterns of bone loss, again, just remember that the defects could be infrabony, where you have defects that extending below the bone crest, or they could be suprabony, whether it's at the where you have the base of the periodontal pocket, like the arrow on the right, which is located coronal to the alveolar bone crest. In old money terms, I know we no longer use the old classifications, but with like the 1999 classification, generally patients that have what we would have deemed chronic periodontitis tended to have present with supra bony defects, whilst you had a lot of patients that had rapid deteriorating bone loss, i.e. aggressive periodontitis, developing infrabony or presenting with infrabony defects. But irrespective, I think it's just important that we're aware, or we sort of think about these considerations as well, because with infrabony defects, they could be more challenging to treat, and at times might require additional training to manage. I think another thing that is really critical that we'll look out for is atypical root morphologies, where if you look at the periapical to my left, you can see that you've got some shadowing there, and this is beyond what would be acceptable as cervical burnout. And for me, it's sort of wondering whether could it be something going on around that root surface, or could it be that you even have two roots that are superimposed on each other? Because remember that even for single rooted teeth, occasionally you could have funny presentations where they have two roots as opposed to one that are fused together. Again, when you look at this lower left first molar, there appears to be vocation involvement, but even beyond that, again, probably wondering whether there is something going on there. And obviously, again with this canine, you can see there is that outline of a root surface, and there's another, and perhaps this is a multi-rooted canine as opposed to just a single rooted canine. An interesting one which I saw recently is a patient that when you look at the top right radiograph, in fact, she just presented a couple of weeks ago because the dentist was concerned that she just had this mid-buccal, very deep pocket measuring about 9 to 10 millimeters that was operating. And when they're taking the radiograph, I mean, when you look at the bone levels, they look really reasonable there. And they could not explain what was going on. And following examination, patient did have what I would deem very relatively mild, perhaps stage 2, grade A type periodontitis. However, something is going on there because when you look, I'm not too sure whether it's a groove or a crack within that tooth, and that, in my opinion, necessitated further investigation, and that is where further radiographic investigations like a CBCT would come in handy, and I'll be talking about that. One of the things we need to sort of also think about is extremely curved roots, or when you have apical pathology that is going on concurrently where you've got some bone loss or periodontitis happening at the same time. So when you're looking at the patient, don't just focus only on their periodontitis, but also look out for all of these oddities because they might explain why certain sites perhaps are not responding despite the patient's compliance and adherence to oral hygiene advice. Now, for me, every time I see the sort of radiographs, especially the bite wings, not the periapical on the right, in particular the bite wings on the left, when I am triaging a referral, I kind of roll my eyes. And that's because they do not give me any information. I can barely see any crestal bone levels. I don't mind having bite wings being sent my way, but at least show me something. And I think it's really, really important that when we utilizing bite wings, they need to be appropriate, because ideally with this sort of view, I can appreciate if the clinician was trying to establish whether there was any dental caries. But if it was for periodontitis diagnostic reasons, then supplemental periapicals or even an OPT will be required. And that's why I've sort of put the periapical radiograph in the upper for the upper left 5, 6, and 7, just to illustrate that you can actually see a lot of detail. I mean, you not only can you see the crowns of the teeth, you can see the root canals clearly. You can even see the floor of the sinus, and that is really, really, really helpful when trying to establish what is going on with the patient. Conventional radiographs are not without their limitations because obviously they're a 2D representation of a three-dimensional object. So you've got to bear that in mind, that the bone levels you'll be seeing, for instance, will be interproximal bone loss, you will not necessarily be able to see your buccal palatal bone plate or your buccal and lingual bone plate. And you can have artifacts as well. And I think one of the things to also remember that this bone loss you're seeing is historic. And that is why when you look at the guidelines for the 2017 classification, actually when you're looking at air, the role of radiographs fall within trying to establish whether there is a stage and grade from a classification perspective. If you're really talking about a diagnostic or a diagnosis statement, you also need to incorporate the patient's status, where you're sort of thinking about whether they're currently stable or in remission or unstable, in addition to their risk factors. So it's really, really important that whenever you're assessing patients, that you're sort of thinking about that, because bone levels alone don't tell you everything. When you're thinking about the periodontium, you're sort of thinking about your the various components of it. You've got your root surface, the cementum. You're thinking about your alveolar bone, obviously your gingiva, as well. Is really important to just think holistically when we're thinking about those patients and trying to formulate a diagnosis of what's going on. I think it's a common question I get when I'm discussing with colleagues. For patients that are suffering purely from periodontitis and have no other dental conditions, do we need to routinely take radiographs? And I think what I'll say on this is that it depends. For patients that are perhaps rapidly deteriorating with excellent oral hygiene, there might be some benefit. But I think for majority of patients, because we don't have any guidelines as you would for caries patients, where with regards to whether they're high, low caries or medium caries risk, and you have recommendations in terms of intervals for taking radiographs. With periodontal patients, you don't. And I'll try and cover instances or indications that we should consider when we want to take radiographs once we have arrived at a diagnosis. So when you require supplementary views, whether it's at the diagnostic stage. So for me, because of the nature of how the hospital works, I don't necessarily have the luxury of being able to take full map periapicals initially when patients come in for my consult. So what I do, often it might be to take a panoramic view. And if I feel that I need supplemental information, I will at a later stage, when I've accepted that patient for treatment, request for it. And that will further aid my plan. But predominantly, I can make a diagnosis from an OPT in addition to the information that I have gathered. So just bear that in mind. When you have deteriorating sites, especially in patients that are well engaged or compliant, that might necessitate you taking further radiographic views. So you've carried out a course or two of treatment, patient is improving at other sites, but this particular site is not getting better. Obviously, there are reasons why that might be. It might be due to operator factors. It could be due to patient factors in terms of anatomical variations or the nature of the defects, like I was saying before, when you have infrabony defects, etc. But you would consider taking further radiographic views for those patients. Non-responding sites as well, where you're doing everything that you can, patient is doing everything that they can as well, and if they are not getting better, there might be some benefit in taking further radiographic views once you've carried out some courses of treatment. Again, for those sort of patients that we talked about, it might be worth getting a referral sent to a specialist, even if it was just for an opinion and some guidance in terms of how to further manage the patient, or for them to actually manage the patient. Um, Often when you send the appropriate radiographs to us, it's very, very well received and appreciated, because it could really save time when it comes to trying to arrive at a diagnosis in a very busy clinical setting, or even just supplement the information that we've gotten, because at least we have a reference to compare with if we are taking further views as well. Again, it comes in handy when we're planning for periodontal surgery, or even further treatment. Might not necessarily be regenerative surgery as well, or even minced, because you wanting to determine whether the morphology around that tooth is appropriate for that sort of treatment, and in us monitoring response to treatment as well. So for instance, for patients that undertake periodontal regeneration, and I will take radiographs to monitor and see how that site is progressing or developing over time, in terms of whether they've remained stable and whether we've gotten that consolidation of the bone following grafting. Again, radiographs have a role to play when you're trying to determine prognosis, because if you're having further deterioration, it might change your prognosis for a tooth or teeth. So I think I've just put this here as a guide of some sort for you, things to sort of consider if you're thinking about specialist referral. Ideally, you want at least about 30% bony support around that tooth, or especially if you're showing the whole tooth. So again, periapicals or an OPT are essential for that. If you're getting irregular bone loss patterns, you've got it for bony lesions. Again, periodontic, endodontic lesions, I'm not expecting you to diagnose that, but you could suspect that something is not looking right here, and you might just want to seek an opinion as well. Again, you can have concurrent but unrelated endodontic problems on teeth that are already periodontally affected. And I think my message is, if in doubt, then please do seek an opinion. I think I'd like to think that colleagues would be glad to help out with regards to that. I think radiographs are extremely integral to planning and monitoring when you undertake periodontal regeneration. So when I've sort of put this image there with the lower right 656, where you've got angular or vertical bone loss in that side. That patient was sent to me, and they had not responded to numerous rounds of non-surgical periodontal therapy previously, and we raised the flap and ended up grafting that. Unfortunately, I was not able to locate the post-op radiograph in good time to be able to put it in for this presentation. But again, from my perspective, having a radiograph was ideal, because I was able to assess not just the morphology of the defect, but also to see whether there was any apical pathology or any furcation involvement, because that sort of has an effect or impact on whether I was going to be undertaking regeneration and what sort of approaches I was going to utilize as well. Now, this is a case that I had managed or undertaking surgery recently. Again, this was a lower right 7, and you can see here there was some angular defect there, and that was April last year. Undertook some regenerative surgery there, and this is about 9 months later, and that site is still well maintained. So you can see how I've utilized radiographs to monitor that site over time, because with regeneration, you're not actually able to go back in to probe for at least a minimum of 6 months to a year, preferably. Now, radiographs, like I've said, don't necessarily provide all the information you require. And when you start to see atypical presentations, or seeing perhaps apical radiolucencies that might be suggestive, or pathology, not expecting you to be able to diagnose it if it's not within your scope and if you've not had additional training. But there's simple things you could do that would aid your referral, or even just getting your dentist colleagues in to see. Vitality testing or sensibility testing is great, because that is how you actually would arrive fully at the diagnosis, not just purely from your radiographic investigations um, alone. So just bear that in mind, that there are other special investigations in addition to radiographs that might provide you with a bit more information, and that would help with your planning. Now, when we're determining prognosis, obviously we're taking a lot of things into play. We're looking at the severity of the disease. We're looking at factors like mobility, the amount of clinical attachment that has been lost. What is the patient's compliance in terms of them executing good oral hygiene practices, and their adherence to it in a long time, and whether there are any risk factors, whether they're modifiable or modifiable. So I've put this full set of periapicals in there, because just looking at that alone does not provide you with a lot more information other than, oh, there is severe disease. So if I were to say to you that this patient is an 80-year-old patient and that has had bone loss for a while over the years and has been managed, I think from a prognosticating perspective, you'll be looking and say, actually, as an 80-year-old, he or she is not done badly. But if I did put the context in as to, this is a 28-year-old female, Caucasian, that has never smoked and had really good oral hygiene, clearly your idea in terms of determining that prognosis for that patient, where you're looking at it thinking that in the long term, prognosis is really, really uncertain for this teeth, because the likelihood of tooth loss at some point, even if they're well maintained, as maybe in their 60s, is high. So I think the point I'm trying to make is, radiographs on their own will not provide you with uh, the information you need to determine a prognosis of a tooth or a prognosis for teeth, but they all play a vital role in trying to make that choice or that decision as a clinician, when you're trying to determine what the prognosis for teeth are. And I'm sure you're quite well aware from the literature that dental professionals are really, really not great, even specialists are not great at determining prognosis. So just moving on to computerized tomography and CBCT, I'm just going to give a little bit of an overview with regards to this, just to sort of get you thinking about other views. And I'm not necessarily saying you have to request these views, because you might not be trained or equipped to do so. But it might be the sort of conversation that, if you're within a practice setting, where you might be discussing with a dentist and saying, perhaps we need to probably think about maybe further investigations like CBCT, and getting a bit of an opinion. And I think it just helps with you having more informed conversations with your dental team and colleagues. So the beauty of computerized tomography is that they can either produce 2D or 3D cross-sectional images of any object uh, from a flat radiographic image. And they can show you internal structures in terms of the shape of the morphology or bone defects, the severity. You can visualize it. They are great for that. But I think the major challenge with them is the amount of radiation dose that conventional CTs produce. So they've got very, very limited use in prosthodontics. However, over in more recent years, saying about the last 20 years or so, the cone beam CT has come into the picture, and the great thing about them is they enable you to undertake this investigation with lower radiation dose, and they are of immense value when you are planning and as well as assessing very complex bone defects. So they are great when you're sort of thinking about dental implants, planning for implant placements, even really complex root morphologies when patients present, as well as your section images that you could sort of uh, take. And the beauty of it is you could just look at a particular area in question, and you can manipulate it. You can turn it around to get a really good idea of what the structures are in 3D. So they're really great resource out there for diagnosis and care planning. But I think because of the radiation dose, you tend to utilize them only when you feel that they are likely to be beneficial to your management strategy. If they're not going to change your management strategy, then you do not necessarily need to utilize them. But if they're going to supplement uh, the information you have, so for instance, that case I was alluding to, where the pocketing was mid-buccal and I had reasonable good bone levels interproximally, and I'm still trying to figure out what's going on around that tooth, a CBCT is great. And that I've sent the patient to have that investigation, and I'm still awaiting the results. When utilizing them, you've got to be familiar with the European Commission's guidelines on how to use them, and you need to adhere to them. Again, you want to keep your doses, with whatever radiographic investigation technique or system you're using. You want to keep your doses as reasonably low as possible. And for the Faculty of General Dental Practitioners, their recommendation is that the CBCT is not indicated as a routine method for imaging the periodontal bone support. So for your box standard patient is coming, you've screened them and they've got code 3s and 4s and you're taking images, you will take your conventional radiographs first before you start thinking about CBCTs. So for majority, I'll say about 90% of patients I see in practice, I do not take CBCT views for them. Okay. So when we've got periodontally compromised patients, they can actually aid in the assessment of them and focations. And I've just put that image there again. And just to illustrate this point, this is not a patient who has periodontitis. She's about 14 years old now. And these images were kindly shared with me by an orthodontic colleague because the patient had orthodontic treatment. She's got a very thin tissue biotype, and you can see that there's some element of gingival recession that was beginning to take place. And they're taking an OPT. Bone levels seem okay, and we know obviously from the limitations that it does not show you what the buccal or lingual cortical bone plate levels are like. So they decided to take a CBCT. And when you look at the image on the top left, you can see that whilst the young lady has reasonably good interproximal bone support, they appear to have lost a lot of their lingual bone support, which is really quite extensive, as well as on the buccal as well. And again, you can see from an occlusal view, you can sort of have the sections, and you can actually see that there's good interproximal bone levels. That's the image in the lower right. But when you look at the buccal plate, it is really, really thin. Now, it's very difficult to tell whether before treatment, whether the tooth was more buccally placed and whether she just naturally, and I suspect she probably just naturally had very little cortical bone plates, because you can just see generally when you're looking that there isn't a lot of consolidation of the bone. So increasingly, it's even used in things like orthodontic planning as well to establish where the patient's teeth are. and it gives a lot more information in terms of management strategy, and also trying to determine from a prognostic perspective as well whether this teeth have a good prognosis or not, and what sort of treatment plan or strategy for managing if the recession continues. There's another case that I just wanted to show you, um, just to sort of get you thinking about looking outside of the box as well at times when you have patients. It's very important to always follow first principles, but also when you look carefully at your radiographs, you might be able to pick up incidental findings that might benefit the patient's future care, and perhaps even change some of the treatment strategies. So this is a patient got anterior pumbi, but that was not why they were referred in. They were referred in for periodontitis, because I think they had code 3s and the ought for palatal to the upper and anterior and the lower anterior teeth, and they were sent to us. Patient's oral hygiene wasn't that bad, and as part of their radiographic investigations, we had taken some periapicals. They had some accompanying radiographs that were sent in as well. And I'm not going to bore you with that, but generally we had put in our radiographic findings. They happened to have a variable pattern of bone loss. They had several infrabony defects, as you can see. But I think one of the things that we started looking at, especially around the lower anterior teeth, was that they did have a significant amount of bone loss just around those teeth that were beginning to extend to as the lower left one, extending to within the apical third of the root length. But can you see that there's some radiolucency there? That was just purely an incidental find, where it just looks like that does not look normal. And that's why it's important that you know what should be normal, and that's where your tooth having a good idea of what the normal anatomy and morphology of teeth is it's really, really crucial. So because we were not sure what was going on there, we did arrive at a diagnosis of periodontitis, but weren't sure whether this was going to have an impact around the management strategy for that tooth, as well as the prognosis. We did a sensibility test that tooth. It was still fortunately responsive. So we sent off to our radiologist in-house, who recommended that we took an occlusal view. So that is another view, but often an occlusal view will not be necessarily relevant for periodontitis patients, but there are instances like this where we could take it, or it was required. And they did write this report, and they sort of wondered whether it was giant cell lesion or odontogenic, I beg your pardon, keratocyst. And they sort of suggested that we probably would need to biopsy and have some histology. So we ended up having to send the patient up to oral surgery. But before we did that, we ended up requesting for a CBCT. And you can imagine our horror and shock when we seen. So from something that appeared just very little, you can see how the lesion is extended all around the apices of this teeth. You can flip, and that's what also talking about, getting different sagittal, coronal views, occlusal views as well. And you can see as you're going from the coronal to the apical levels, how extensive that lobulated lesion was. And eventually it ended up being a really rare thing called a Boyd cyst, and it got enucleated, but we still ended up, I think in the process, unfortunately, the patient ended up having to lose that lower left one, but we're able to manage and stabilize the periodontal condition as well as manage the patient. So radiographs are really, really useful. And I think in summary, they're integral for diagnosing periodontitis and code 3 and code 4 patients. But I think the thing I would say is It's really important with your code 3, code 4 patients that you determine what views are required, and it does not necessarily need to be periapicals all the time. So if you've got a patient that has got code 4s in the posterior sextans, then you could take perhaps um, not necessarily full map periapicals, but periapicals of the posterior sextans, or you could take an OPJ. Okay. Whilst they're ideal, like I said, you've got to determine your patient factors. Can they tolerate intraoral films? What sort of equipment you've got, within the practice, the total radiation dose as well, taking full map periapicals as well. I, it does come with quite a relatively high dose when you compare at times to just taking one big film. What affected site. Generally, there's no requirement to take regular radiographs for patients that are suffering from periodontitis unless there is an indication to do so, like I've alluded to in this lecture, also in this talk. Radiographs obviously have a role in monitoring and managing patients. And remember that they have their own limitations. And if you're ever in doubt, please do not hesitate to seek a second opinion. So thank you very much for listening, and I'm happy to take any questions if we've got any. Thank you.
Thank you very much, Adejumoke. We do have a lot of questions, actually. I'm just going to go straight to them. So CBCT is so detailed. Why do we not use this routinely with patients with perio code 4 sextants?
It's due to the radiation. They do have a high dose of radiation. So generally with the guidelines, if it's not going to change your management, you do not need it. Because remember that the bone loss is historic. What is more important is what the risk factors for that patient. What is their status? Because obviously we're trying to move them from being unstable to becoming stable. So it's really, really important that we sort of think about those factors before we think about just going all the time for CBCT. So you've got to weigh the benefits of that. If it's not going to add any additional information to what you're going to be doing, then there is no need for it.
Thank you. How can you tell buccolingual palatal bone loss on radiographs?
It's very difficult unless you're taking perhaps maybe parallax views, because that's the limitation for your conventional radiographs. You can't really see the buccal or the palatal views in terms of the bone levels. But occasionally, at times, depending on how the tube has been positioned, you might see two levels. I don't think I've got any radiographs to illustrate that, but at times you could see two levels of two bone levels, and that sort of gives you a little bit of an indication of perhaps it's a buccal or palatal.
What recalls should we do for radiographs to monitor bone levels once first taken for our periodontitis patients?
There are no recall intervals. You've got to determine based on what you see. I think the first rule of thumb is if the patient is improving, obviously you've got to think about this patient holistically. If they've got high caries risks, then you've got to determine whether you're going to need views to demonstrate any progression of caries. But if the patient is a low caries risk patient and they're suffering from periodontitis, whilst you're managing them, you don't need to take routine radiographs. You'll probably be guided more by the caries risks. If they're compliant and you're getting sites that are not responding, then you might consider taking radiographic views to try and establish what's going on. If those sites are deteriorating despite excellent oral hygiene and plaque control, yes. But if I've got a patient that is not compliant, there is no point, because it's not going to change what I'm going to be doing, because the whole essence is trying to get them compliant and you're trying to stabilize the condition.
Hi there. I was wondering, are therapists allowed to do vitality tests, please?
Yes, there's no reason why you can't do it if you are trained to do so. It's all within your what you need to think about is what's within your scope of practice. So in Liverpool, for instance, our students would undertake vitality testing and report it. Now, in terms of the interpretation, that's a different thing. And that's why if you're working, obviously, with, say, for instance, in direct access setting, if you don't have a dentist on ground, you might just say, a vitality test, and this is my finding. Is that a positive or negative? Let whoever you're referring to, whether it's a dentist or a specialist, make that decision. But all you're doing is you are providing them with more information.
Good. Hello, I would like to ask a question. When examining radiographs and noticing bone loss, especially in elderly patients, does bone loss occur naturally with age, or is it mainly due to prolonged exposure to dental plaque, indicating that the patient has periodontitis?
So generally, right, bone is never static. You've got constant remodeling of bone throughout life. But often there is a good balance of bone being taken away and bone being redeposited. Obviously, where the immune inflammatory response you get in susceptible individuals that end up with periodontitis, there is a disbalance, right? And that is why you get extensive bone loss. We all lose some amount of bone, but often it's not that much. And that is why when you're looking and when you look at the classification, they allow for anything between 0 to 10% as being normal. And that's why you will see that when you look at the classification, it starts with, I think, about 15% bone loss, because we do allow for some measure. So that will still be within normal range, because that's taking into account that there is some bone loss that might take place, especially in very old people, but not a lot.
I think you've answered this one, but are full mouth PAs always necessary? At uni, some supervisors would say if you can see bone levels on bite wings, don't take PAs of these areas. But others would say PAs are a must in all cases. And I feel like I'm now none the wiser due to the different opinions from various supervisors.
Okay, I always go by what the guidelines stipulate, and I think I came prepared for that question. So I'm just going to read out what is in the BSB guidelines. Okay. It says radiographs should be available for all code 3 and code 4 sextants. The type of radiograph used is a matter of clinical judgment, but crestal bone levels should be visible. Many clinicians will regard periapical views as essential for code 4 sextants to allow assessment of bone loss as a percentage of root length and visualization of the apical tissues. So, like I said, it does depend on that case by case and the circumstances in terms of easy access to taking periapical radiographs, patient tolerance, etc. So ideally, yes, you might want a periapical of the area, but again, it depends on how many sextants are involved, etc. But you can still get a good idea of what's going on with your panoramic views as well. I think where it will be a big no-no, for instance, if you've got a code 4 patient that you're using bite wings to look at bone levels, because you're not going to really see anything. For very early bone loss, you might see, so maybe a code 3 patients where you're thinking, is it gingivitis case or is it a periodontitis case? You might use bite wings, but ideally that's not great. But you can use either panoramic views if you've got multiple sextants, or you just use your periapicals.
Thank you. What should we do when our rooms as hygienists don't have radiography equipment and the dentist won't take them? How do we diagnose? Thank you.
Okay, that's a really difficult one because ultimately, like I say, you need to have the radiograph to be able to diagnose. And from a dental legal perspective, you've got to think about that. I think, interestingly, I think a while back, I had one of our students that have graduated contacting me about a case where they felt they didn't have the right views. And what I advised was it's probably worth you having that conversation as a team within the practice as to what to do. Because obviously, patients can come to see you under direct access. You can always refer the patient to go take radiographs elsewhere. I mean, in the past, we did have a service, I don't know whether it's still ongoing, where patients could be referred in to have radiographs. I think,
Okay.
provided you are comfortable that you can report, I know for periapicals, within the scope of a therapist, you should be able, if you have got the training, you should be able to interpret and write it up as in what is within your scope. We're not expecting you to sort of diagnose or write about the periapical radiolucences. You can comment on it, but with an OPT, obviously you need a dentist as well to give a bit of an overview and to sign that up because there might be other things that you're missing out. So just ensure that whatever views you are taking or you're requesting, that you are doing it within the scope of practice. But there's no reason why you can't advise or you can't perhaps refer the patient elsewhere to have it taken. But I will say have a chat as a team and come up with a strategy.
As mentioned, healthy bone levels are 1 to 2 millimeters in adults. However, in some adults who have had ortho treatment, can this reduce the bone level a 1 millimeter or 2 more or blur the crestal bone on the radiograph?
Very good question, and I'd really omit that. There are times where you can have further bone loss, either because you've had tooth movement or surgically removing it. So crown lengthening procedures as well will be another one.
Okay, and then, hi Gemma, in terms of vacations, I sometimes find that some vacations that initially probed as grade 1 with the neighbours often has horizontal bone loss on the lowest buccal sublingual, for example, and on sub-PMPO, we actually find that grade 2 when subcalculus is removed. This sort of defect I can't see in a conventional radiograph, or maybe I'm just reading them wrong. Would a CBCT be useful in these circumstances? I don't have any experience with them, so I would just like to know if they would be of benefit. Hope that makes sense.
If the patient was cleaning quite well, so I think it depends at what stage you want the CBCT. In my mind, if you've got a patient that you've just diagnosed and you carried out your full periodontal assessment, you checked the furcation prior to you carrying out therapy, it was a grade 1. Yes, you've removed the calculus, you're bound to get some shrinkage, you're going to get better access. So that's not going to change anything. So a CBCT might not be appropriate. However, if you felt that that site was deteriorating and you're taking further radiographic periapical views and you're not getting anywhere, I think it's actually perhaps maybe more in the planning stage in terms of whether surgery might be required, etc. But I think for a dental therapist, I probably would not say a CBCT at that stage will be required. If you're worried about that furcation site getting worse despite good treatment and patient being compliant, then you should be referring that patient in.
Okay. Can you please repeat the cyst type, please, in your case?
Is it botryoid cyst? So is it BOTYROID?
As code 3s don't show any bone loss on radiographs, does this still warrant a pocket chart or do we deem them as false pockets?
So what the guidelines say is if you've got a code 3, irrespective of whether they've got bone loss or not, you will go through your initial therapy phase, which would comprise of you uh, carrying out your plaque and bleeding indices, providing oral hygiene advice or education to the patient. You might undertake some supragingival PMPR, that's your step 1 management, and it's expected that at the 3-month mark, you will carry out a full periodontal assessment at that stage. So irrespective of whether they got bone loss or not, the expectation is that is about patients taking ownership of their oral hygiene so that whatever superficial inflammation you've got, you can get it down.
Okay. If there is a single code for pocket during a BPE, only ones elsewhere, do we still take a full mouth 6-point pocket chart?
Not necessarily. So if there's a code 4, well, ideally you want to, at least as a bare minimum, that is a baseline, right? What the guideline says, if you've got a code 3, you might choose, at that 3-month mark after initial therapy to just do a 6-point chart or a full periodontal assessment of that sextans. But nothing stops you, because remember, these are guidelines, right? If you've got a good reason, you can sort of go beyond it. So that they're the barest minimums that they're expected. So in my practice, irrespective of whether it's a code 3 or code 4, I tend to just get a good idea of what's going on and just do a full mouth periodontal assessment. It's not going to take me much longer. And at least I know that I have that and that I'm not missing any sites. And then subsequent ones, I might just want to focus on maybe the area.
Okay, I think we're going to have to get you back if you'll come back, Adejumoke, and do
That's fine.
another perio lecture. But hi, just to confirm, after how long can you probe pockets post a non-surgical periodontal therapy? You mentioned 6 months. Is that after regenerative surgery?
That is regenerative surgery, please. Obviously, for non-surgical periodontal therapy for our periodontitis patients, anything from 8 weeks to 12 weeks. And the reason behind that is whenever you carry out your fantastic subgingival PMPR, what you have to allow the tissues to heal. And it takes about 6 weeks for you to get the maturation of the collagen fibers. That's why we don't go in earlier. So the longer you wait, the better. But for patients that have unstable disease, anything from 8 weeks to 12 weeks, MAC will be a good time to carry out your full periodontal assessment.
Okay. When a patient the BP is zeros, but there is 30% bone loss in a 45-year-old, no pocketing, less than 3 millimeters, no bleeding on probing, what is the classification? A, gingival health, or B, general periodontitis stage 2, grade A stable?
That seems like an exam question for me. I think what I will say is,
you see it there actually, Adejumoke.
And that's one of the limitations, right, of the BPE. Remember, it's a screen. So first things first, when you're examining a patient before you screen them, if you notice that there is interproximal recession, gingival recession, right, that's already telling you that there is some periodontitis that has taken place, right? So when you're carrying out your BPE, you've got to bear that in mind. Now, if you have radiographs and there is evidence of bone loss, then that is a key feature of periodontitis. That patient has periodontitis. So it will not be, it will be periodontitis, but they might be stable. So it will be your stage 2. Sorry, I didn't hear the other bit. Whatever stage, whatever grade, but that's where the disease status comes in. And you will treat that patient as a periodontitis patient. Because remember, periodontitis is for life, and patients can slip in and out of stability as they progress. Life happens. They're ill or they have a risk factor and they're not clean as good as they used to previously. They can go from being stable into remission into instability. So always bear that in mind.
I think because you've been waiting a while over on the chart. Stage 1 states less than 15% or less than 2 millimeter attachment loss in the CEJ. You're saying 50% or up to 2 millimeter is clinically healthy, normal. Then what is the point of stage 1?
So with stage 1 is anything really, right? There was a lot of debate when this classification came in. Stage 1 is very, very early bone loss, right? Remember when you look, right, at a radiograph, often in a healthy individual, you'll have good cortication of that crestal bone, right? When it starts to look fuzzy in appearance and it starts to wear down, that's telling you that there's something going on there. Remember, I said that generally you can accept up to 5-10%, but anything more than that, we start to worry, which is why you have that classification for of less than 15%. As being stage 1. But I think you've got to look holistically. You take into account things like patient's age, your knowledge of how bone remodels, how it forms, how it remodels, because you always have osteoblastic and osteoclastic activity throughout life. So you've got to sort of put all of that uh, in your mind as you make that judgment call.
I was going to ask the same question about working in the room. This hygienist is saying, asking the dentist to take radiographs for code 3s and 4s, but they rarely do. Now, there is an OPT machine at the practice, and she's asking, or he, is it acceptable for them to take and review an OPT, given that they feel confident assessing bone levels, but not necessarily everything else?
So the dentist, I don't see any reason why they should not be able to assess everything else, because they are trained to undertake radiographic investigations. They should be able to interpret it, they should be able to assess it, and they should be able to report on it. So if they're not able to do that, then I'll be querying their competency. Then they probably need to go back on some refreshers. And I know it's a difficult one when you're having to deal with people, but every dentist should be able to report on an OPT. And if they can't, they should employ the services of a radiologist. They can pay for that service. Often it's about £50 or to about £100. So they can choose. Because at times, even with my training, I might think that there is something suspect. So I give you an example. With CBCTs, I am not trained to report fully on it. I can tell that something might be wrong, but often I would request for a radiographic report from a radiologist at the same time because they are trained to do that. So if the dentist is not comfortable, then perhaps it's something that there needs to be a dialogue as a team in terms of determining what do we do. And that's about taking ownership for their learning.
There was a debate on the hygiene forum about the occlusion bruxism can lead to bone loss. Any thoughts on this?
Okay, so you're talking about excessive traumatic, or what they used to be called traumatic occlusion. So it's excessive traumatic forces, right? Now, there are two types. Often when you have excessive occlusal trauma, it does not lead to periodontitis, right? But in patients that are already suffering from periodontitis, it can lead to bone loss, further bone loss deterioration, if it's not controlled. So in old terminology, it used to be called secondary occlusal trauma, where a patient has periodontitis, they're bruxist, or there's some excessive occlusion issue in terms of the tooth being in heavy contact, and then you're getting further bone loss as a result. So often radiographically, what you will find is that funneling. So there's usually a funneling shape or appearance of the bone around that tooth. So it doesn't, it can make periodontitis worse. That's it, but it does not cause periodontitis.
There's lots of fabulous webinar. Thanks, Adejumoke. Excellent. Just so many. And actually, Adejumoke, just want to say what an excellent presentation. Do you have any in-person lectures coming up? I feel I can learn so much from you. And that's from Gemma. And I'm on it, aren't I, Adejumoke?
Yeah. We'll work something out.
You've just got a great way of explaining things, and this is what we need. You know, this is the nuts and bolts of what we do every day, and these are the questions that we have asked. And I know we've really run over and over your time.
Oh, no, I could talk perio all day.
Please send them in to me, and I can send them on to Adejumoke. But I feel we're really over the time for her now. We need to let her go and have an evening because she's actually not even got home yet, have you? So
No, it's fine.
again, the saying thank you, Jamoke. So
Thank you so much for having me.
we
Uh,
definitely, if you'll come back,
I will.
won't
I
keep you
will
as
for
long.
sure. I think for me, I always go back to first principles. I always want to find out why. I need to be able to figure out why I'm wanting to do what I'm doing. And I think with perio, because there's so many gray lines, right? This, as I say, there's so many shades of gray in perio. It's difficult because we're using the same parameters to assess patients, whether they are stable, whether they're unstable, and it makes it really, really difficult to have clarity as to what you need to do at times.
Yeah. Okay. And Olivia's here that you met in Frankfurt saying, thanks, Jamoke, could
Oh,
to listen
bless
to
her.
you all day.
Oh, thank you. I think we need to have a perio gang retreat or
Well,
something where we talk perio endlessly.
absolutely. Why not? Let's organize it. If there's any further topics that you would like, please let us know, because if we know the topics, and this has been so busy this evening, and I was inundated asking about a recording, which it is recorded. It'll be on the My NSK website on demand in 10 days. So you need to register and sign in for that and get your certificate. Again, thank you, Jamoke. Really valuable. We're going to let you go now and have a lovely evening. Thank you.
Thank you so much for having me, and
Thanks.
thank you everyone for sharing your evening with me. Enjoy the rest of the week. Bye now, Shimon.
Lovely.
Bye
Bye,
bye.
everybody. Take care. Bye-bye.